Nasal cavity and paranasal sinuses. Nasal cavity sites include the vestibule, which is the edge of the nasal cavity or the nares, the septum, the floor, the lateral wall, and the roof, which are the ethmoid sinuses on the left and the right. The sinuses include the maxillary sinus, the frontal sinus, the ethmoid sinus, and the sphenoid sinus. Squamous cell carcinomas are the most common here. Anatomy: be aware of Angren's line, which is from the medial canthus to the angle of the mandible. Upper cancers generally do worse than lower cancers on Angren's line. In terms of workup, additional workup includes nasal endoscopy, MRI of the head and neck, the CT of the primary site, and a chest CT. Staging for nasal and ethmoid sinuses: T1 is one subsite plus or minus bone invasion. T2 is two subsites plus or minus bone invasion. T3 is cribriform plate, medial wall or floor of the orbit, the maxillary sinus or the palate, COMP, cribriform plate, orbit, maxillary sinus or palate. T4A is skin of the nose or cheek, the anterior orbital contents, the pterygoid plates, the sphenoid or frontal sinus, or minimal anterior cranial fossa. T4B is the orbital apex, the dura, the brain, the middle cranial fossa, cranial nerves, but not V2, nasopharynx or the clivus. Wang staging for nasal vestibules, essentially skin cancers in cosmetically important areas. Radiation is preferred. T1, confined to skin. T2, invades subcutaneous tissue or cartilage. T3 invades the bone. Maxillary sinus cancers have their own staging. T1 is maxillary sinus mucosa but no bone. T2 is bone erosion or extension to the hard palate. The middle nasal meatus, it excludes the posterior extension to the wall of the maxillary sinus or the pterygoid plates. T3 is posterior wall bone erosion, subcutaneous tissue, floor or medial wall of the orbit, pterygoid fossa or ethmoid sinuses. T4A is the skin of the cheek, anterior orbital contents, pterygoid plates, sphenoid or frontal sinuses, infratemporal fossa or cribriform plate. T4B is the orbital apex, the dura, the brain, the middle cranial fossa, cranial nerves, nasopharynx, or clivus. Esthesioneuroblastoma, small round blue cell cottage staging. A is confined to the nasal cavity. B involves nasal cavity and paranasal sinuses. C extends beyond nasal cavity and paranasal sinus. D, lymph node positive or distant Mets. Management of nasal and ethmoid sinus. See management at right. Nodal irradiation is controversial. Nodes are unlikely. If the patient is clinically node positive, then dissect. Can consider elective nodal irradiation if they are high stage or high grade, or esthesioneuroblastoma. Generally, you would cover levels 1B to level 2. If considering it, add retropharyngeal if posterior 1/3 nasal cavity. If node positive, then do 1B to 4. Low dose region, 54 for intact or 60 gram post-op. Entire ethmoid sinus from inferior turbinate to and including cribriform plate. Laterally include the nasal cavity, the ethmoid sinus, the ipsilateral maxillary sinus. Posteriorly include the sphenoid sinus. For nasal vestibule cancers, less than 1.5 centimeters and well differentiated, radiation to primary, and 2 centimeters to 66 gray. Greater than 1.5 centimeters are poorly differentiated, radiation to primary and lymph nodes. 50 gray to bilateral facial lymph nodes, 1B to 2, 66 gray to primary plus 2 centimeters. If lymph node positive, radiation to primary and lymph nodes. 50 gray to bilateral facial, levels 1B through 4, 66 gray to primary plus 2 centimeters. Maxillary sinus, C at the right. Nodal irradiation is controversial. Practice patterns vary. Consider elective nodal irradiation of T3 or T4, especially if high grade. Levels 1B to 2, usually ipsilateral, unless tumor crossing midline, then consider contralateral. Low dose region, either 54 gray intact or 60 gray post-op. Entire maxilla, the lower edge is the posterior border of the maxilla or hard palate. Medial is the nasal septum, unless it went through midline, and posteriorly includes the pterygopalatine fossa and infratemporal fossa. Esthesioneuroblastoma can be in the ethmoid sinus or the maxillary sinus. You treat as per those sites. Cover bilateral retropharyngeal, level 1B through 4 for all but cottage A. Evidence, general NCCN paradigm for paranasal sinus, surgery, and then post-op radiation for all except T1 to 2 N0 maxillary that are perineural invasion negative, LVSI negative, margin negative. Consider re-resection for positive margins. Consider chemoradiation for positive margins or extranodal extension extrapolated from Bernier and Cooper. All incorporate chemo more readily for SNUC, small cell, and sinonasal neuroendocrine carcinoma. If the patient refuses surgery or is medically inoperable, then typically radiation for T1 to T2 or chemoradiation for T3, T4 node positive. T4B is unresectable. Don't cover the neck if adenoid cystic. Remember, those do not tend to spread to the nodes. Treatment planning techniques can use water balloon or obturator to fill the resected cavity.